The following program presents principles designed to promote good health and is not intended to take the place of personalized professional care. The opinions and ideas expressed are those of the speaker. Viewers are encouraged to draw their own conclusions about the information presented.
Welcome to Wonderfully Made. My name is Stoy Proctor, and today our topic is problems with the prostate. I have as my guest Dr. Alan Handysides, who is a specialist in many areas. He's got many degrees, and I'm certainly happy to have him with us today. Dr. Handysides, I'd like to ask you a question. Would you explain the prostate and how prevalent is prostate cancer?
Thank you, Stoy. That's a good question. First of all, the prostate is a gland that sits beneath the bladder in the male. It is very beautifully and anatomically designed so that it wraps around the little tube that drains the urine out of the bladder. And it has a special function. That function is to add fluid to the rest of the semen and protect and feed the sperm that are in that fluid. Unfortunately, as you have said, nearly every male will develop a problem with the prostate if he lives long enough. So one of the problems that some of our older viewers may be aware of is that as the prostate gets older, it gets bigger, it enlarges. The medical term for this is prostatic hypertrophy. Now, the prostate has an outer edge and an area that is where predominantly cancer occurs. But the innermost portion is where this hypertrophy takes place. And it starts off as clusters of cells start to grow, and you begin to get increasing numbers of these clusters, and they coalesce to form a generally enlarged gland, which squeezes the little tube that comes out of the bladder. Consequently, males begin to find when they pass their urine that the flow starts to be a little less powerful, a little slower, and that is often the first sign of prostatic enlargement.
How many people are affected every year by this condition?
Well, if we're talking about prostatic hypertrophy, I would think probably 65 to 75% of males will notice some changes in their urinary flow. The others probably have changes but don't notice them. Mm-hmm. It's probable that if we lived to the age of 100, nearly 100% of males would be found to have, at autopsy, not necessarily in life, at autopsy, found to have cancer cells in their prostate.
Now, this is a question probably people who have prostatic enlargement won't need to answer, but or won't need to know the answer to. But how do you know whether you've got problems with the prostate? You've mentioned the decreased flow of urine, but any other symptoms that you might have?
Sometimes people can have no symptoms, no signs of a problem. And in that case, they can live their lives in blissful ignorance. And many, many people have, and for many, many years, people did not understand that there were problems. But we do recommend that there are certain groups of people who should begin prostatic surveillance maybe a little earlier. For instance, we know that black people, North American blacks, living here on the continent, particularly because we're in a northern climate, seem to have increasing risk of prostate cancer the further north they go. So a black man living in Canada has a greater risk of prostatic cancer than does one living in Florida. So we have an environmental factor that may be playing a role. Genetic factors probably too. Mm-hmm. So we recommend that American blacks should begin surveillance of their prostates maybe around the age of 40.
But now that's with blacks, but with every man, sooner or later they're probably going to have problems in this area, right?
Yes. There is a little controversy and a little argument about just how avidly we should screen for prostate cancer. I think that with the American black we should screen early because they tend to have a more aggressive prostate cancer than do whites. In white males, we suggest that probably by the age of 50, they should also begin a program of surveillance.
Now, suppose I've been diagnosed as having enlarged prostate. When does a physician begin treatment? How do I know whether treatment should start?
Let's talk about prostatic enlargement. First of all, not everybody with an enlarged prostate is going to require treatment. This is because the symptoms may be a slowness in urinary flow, but that's not a life-threatening problem. And then we say, well, what kinds of treatment can be offered? Some of the treatments that are offered are medical treatments, such as giving medications that block the conversion of hydroxytestosterone into the active form. Now, that enzyme blocking can reduce the amount of testosterone and therefore reduce the hypertrophy. Another approach is to give a beta stimulant, which is a drug that actually causes relaxation of the bladder floor and lets the urine flow more easily. So many people who are having a little slowness, a little difficulty, maybe a little dribbling, these are all symptoms of this problem. They may go to the doctor and say, can you help me? And he may give them a medication that relaxes the bladder floor.
Do you have any names you could mention?
I don't think that it really
matters.
Goes. Clonidine is the name, but I don't think that that matters. I would want people to go to see their doctors.
Sure.
One of the natural things that people can have, one of the natural remedies that has actually been shown with studies that are reputable studies, is the use of saw palmetto. And the use of saw palmetto is an herbal remedy that in this situation is shown to improve the flow and improve the situation without having very many side effects. So medically or herbally there are approaches that can be made. But if we move from the medical, we're then talking about surgical approaches.
And what about, I've heard that some people, the physician goes and reams out.
Well, that's a surgical approach, yes.
This is a surgical approach.
That's a surgical approach.
In other words, surgical approach doesn't always have to just be removal of the entire prostate.
No, it doesn't have to.
That's one approach, right, Bill?
That is one approach.
Yeah, okay.
You see, one would prefer to have as less an invasive a procedure as possible. So if, for all intents and purposes, this is a benign prostatic hypertrophy, then you can go and see your doctor, and the physician can do what's called transurethral resection of the prostate. Basically, they take a very fine tube, insert it up through the urethra, which is not a very pleasant thought to many men, but through that little tube they then have a little loop that is electrified, and by moving the loop up and down they can shave off slivers of prostate, which are then washed and irrigated out, slivers of prostate to widen the opening through the prostate gland. And that is a very successful surgical approach.
Is there any other approaches?
Well, yes, there are many, many innovative approaches.
Well, I mean successful approaches.
Successful. They have used microwaves, that they will put a probe up through the prostate and then microwave the prostate. Sometimes they can put a cold probe up through there and they can actually chill or freeze sections of the prostate, and then that will die and shrivel back and open the pathway. Now, sometimes people with prostatic hypertrophy have a blood test done called a prostatic specific antigen. And when they get that blood test done...
And we know that as PSA, right?
PSA. When they get that test done, it can be elevated in prostatic hypertrophy. But that causes a problem because it's also elevated in prostatic carcinoma. And then we start to have a problem as to what's going on in this situation.
Now, you've talked a lot about the enlargement. What about prostate cancer? How do I know when, if I've got an enlarged prostate, when do I know, when should I maybe get some more tests done to find out if I've got cancer? Well, I'm a little, I could be a little worried about it.
You see my index finger? I'm wagging this finger because all doctors know that the rectal examination to feel the prostate in the male is very important, because the outer wall of the outer surface of the prostate is where cancer usually begins. And so by feeling across that posterior wall of the prostate, it's possible sometimes to detect a knobbly feeling or a firmness to the prostate that is unnatural. If you have an elevated PSA and you also feel that knobbliness, the doctor is immediately going to say, I think we should move to a more definitive diagnostic procedure, in which case he'll use an ultrasound. And they will then put a transrectal ultrasound. The transrectal ultrasound goes up behind the prostate. It emits these sound waves. They're not electromagnetic, or they're just sound waves. It emits the sound waves. The sound waves go through the tissue. They meet against resistance, are bounced back, and the computer image that is made from all of this very modern technology will then show an outline of the prostate. And they can then see if there are indeed nodules or areas in the prostate that have an altered texture or an altered density to these sound waves. If they do find this, and if the PSA is elevated, then we're going to go to the definitive step. All cancer needs to be definitively diagnosed.
And how do they do that?
And the definitive step is a biopsy. So a needle will be taken. It can be done transperineally, it can be done transrectally. It doesn't matter how. It's a longish needle.
Now, for the audience,
Painful.
Explain this trans. What do you mean by
across.
trans?
It can be across.
Across.
So it's across. So the needle can be inserted across through the rectum into the prostate gland.
Through the rectum.
Or
Okay.
it may be come up
Through the
from
penis.
below. No, not through the penis. Through the perineum, the base of the pelvis there. Through that into the prostate. It's done under an ultrasound, so the directions, they know they're putting it exactly where they want to put it. And then they will aspirate cells from that area. They may do 10, 16 samples to see if there's any prostate cancer cells there.
Now, you've mentioned so far, first of all, we should go see our physician if we think we
Definitely.
have a problem. And if we're black, maybe over 40 or 45. If we're in other ethnic origins, we should go maybe when we're 50.
Yes.
And maybe we should go every year, at least once a year,
I think
probably.
it depends on what
If
our
we
age is and what our risk factors
If we have an
are.
enlargement, maybe going once every year, right?
Yes. For instance, my father died of prostate cancer.
Okay.
So I know I have a 15% greater chance than a man whose father did not die of prostate cancer. So I take more care of myself in this regard so that I go regularly for my screenings and checks.
Now, okay, so we go see our physician. He takes a PSA test, blood test. If he finds some problem, he might do an ultrasound to see what kind of image we have on the prostate, and then he might do a biopsy.
Yes.
All right. If he finds that the biopsy is clear, there's no cancerous cells, then what?
Then he will put us back to routine sequential follow-up. Because it's very important, and I would like all of our people who are watching this program to understand, that you can still have prostate cancer even with a normal PSA, which means that it's not the absolute level, but it may be the trend of the PSA, which is so important. And so we would like our listeners, and particularly viewers, if you're out there listening to me and you are wondering about this, regularity in plotting and checking your PSA level may show, because if it goes along flat, 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 and then suddenly, pooh, it starts to go up, that indicates that something needs to be done. Investigation needs to be made.
What's a normal PSA level?
A normal PSA level is between 1 and 4. Usually we like it to be less than 1, but between 1 and 4 it's normal. Though studies have been done that show that even at a PSA of 1, there may be 6 or 7% of the male population in an older, over 70 age group that actually do have cancer cells in their prostate.
Now, let's take another scenario. Let's suppose someone has a reading of 8 or 10, and that stays steady for years. There's no biopsy. There's no biopsy.
No cancer on biopsy.
No cancerous biopsy. There is enlargement. What kind of situation?
Well, then in that
how would you diagnose that, or what would your prognosis be?
In that situation, if you've done biopsies, you know that you cannot show cancer, he has an enlarged prostate, then you will attribute those elevated levels to the prostatic hypertrophy itself. So that the benign enlargement is producing more of this antigen, although it is not malignant cells that are producing. But still, you want to watch that individual very
at least a yearly
closely,
basis.
At least. Probably with levels like that at 6 monthly intervals.
Okay, let's suppose now by the way, what will our family doctor be able to care for all this? Or should we go further?
Family doctors are a linchpin in healthcare system, especially if this is a family doctor you know well, you can talk to, you can converse with, you feel at ease with. That doctor is a wonderful confidant.
Now, I'm a little confused about this linchpin. What does that mean?
Because he is the key in seeing that you get
He's a
very
gatekeeper.
good. He's the
like
gatekeeper.
A gatekeeper. Okay.
He is the person that is going to look out for you. And so if he finds that you have an elevated PSA, or he is suspicious, or he has ordered an ultrasound, and there's something being found, he is then going to refer you to a urologist in your community who is well-versed, well-experienced, and able to take care of you. And that's where you trust your family doctor. You don't know the urologists in your area, but the family doctors get to know which practitioners give good service, are very knowledgeable, very competent and capable. So your family doctor is a wonderful advisor, but not necessarily the one who's going to give you the advanced treatment.
Alan, suppose that I've done my biopsy and I go back to the doctor for the report and he tells me you've got cancerous cells. What's the next step? I mean, besides my devastation and having a friend that's dying of prostate cancer and others that have cancer, this is serious. And I'm devastated, I know, as many people are that have cancer. But what do the doctor and I do now?
Well, you know, I'm very pleased that you talked about the devastation of diagnosis, because I don't think that physicians nor patients really understand the enormous weight that suddenly falls on an individual with a diagnosis of cancer. The good news about prostate cancer is that it is usually, and I say usually, not going to be the disease that kills you. You're going to die of other things. Secondly, this is where when we began we said this isn't a disease that affects just the individual. The whole family is going to be involved in this. And that's where a good, loving, supportive wife and family can come around and give hope. Hope is such an important ingredient when we are talking about cancer. Such an essential ingredient. And you know, that's where I'm a Christian physician, and I'm unabashedly pleased to say so, that not only do we have the support of the family, but we also have the support and the feeling that our Lord and Savior Jesus Christ can support us and help us go through this very difficult time. It's like Psalm 23 says, "Yea, though I walk through the valley of the shadow of death, I will fear no evil, for thou art with me." So it's nice if you can have a Christian physician.
I shall not fear prostate cancer.
I will not fear prostate cancer. See? Now, the
diagnosis. What do we do, though?
The diagnosis.
We've got to do something about it.
Right. The diagnosis has been made under the microscope. Under that microscope, they will also look at the sort of cells, how they're dividing, how aggressive they appear to be. Is this a cancer that is particularly aggressive, or is it an indolent, slow-looking cancer? And they will assign to it a score called the Gleason score. A Gleason score will tell us if it's very aggressive or if it's very indolent, which may be important as to how we manage it. For instance, if I'm 90 years old and I've got a very lazy, indolent cancer, I've also got diabetes, I've had 3 heart attacks, my kidneys are failing, I've got liver troubles and so forth. My prostate cancer is the least of my worries. See, it's the least of my worries. If I'm a 45-year-old and my prostate cancer is a very aggressive, Gleason, you know, advanced, I don't want to give the numbers because we don't want to scare people, but it's advanced, then not only myself but my doctors are going to look and say, we need to be more aggressive in the management of this cancer.
What's my options?
Well, before we do options, we have to stage it.
Okay.
See? Because
what's staging then?
Staging is different from classifying. Classifying tells us how virulent, how aggressive, how it's going to, you know, go after us. But staging tells us how far has it gone.
Okay.
See? Now, if it's just confined to the prostate, stage 1, we're very pleased because we know that that has an excellent, excellent prognosis. If, on the other hand, when we detect it and find it, we do an X-ray and a bone survey and a bone scan, as people will be asked to do, and we find it's already in the pelvis and in the femur and something like that, we know that this is now stage 4. This is metastasized a long way. We may find it in between stages. It may have just metastasized outside the prostate. It may have gotten to the bladder or to the rectum. It may have gone in the lymph nodes. You know, there are degrees of spread. So we'll stage it 1, 2, 3, or 4. And the treatment options depend on those stages.
Okay, let's go through those treatment options. First of all, stage 1.
Well, for stage 1, we have a potentially curable situation. So how are we going to cure it? Well, you could undergo a prostatectomy, a radical prostatectomy, in which the prostate is taken away
surgically.
You remove it, you put it in the surgical pot, the pathologist looks under it, says it looks like it's all here, all margins are clear of cancer, we've got it all in the pot. Some people like that.
Would that be enough?
Well, for some it may. Some will have a radical prostatectomy where there will be dissection of lymph nodes up para-aortics, around the pelvis. They'll dissect all those nodes, gather all the nodes in there, put those
That would probably be stage 2 or 3, though.
That would be a stage...
Right.
Well,
Okay.
not necessarily.
Really?
No, because if it's a stage 2 or 3, we're not going to be doing this surgery because
It's too late.
The horse has fled.
We're going to go to
But
something
we are
other.
just ensuring that we've got it all. See? The problems with surgery are that it's sometimes difficult to do the surgery without damaging nerves.
What kind of nerves?
Well, the pelvic nerves that are important for bladder control and also sexual function.
So now we're getting serious.
Now, that is one of the problems. Bladder control is a serious problem, but so is impotence to a young man. And a 40-year-old is a young man. So they now have newer surgeries.
But a 60 or 70-year-old doesn't have to worry about it, right?
Well, I don't know about that. You speak for yourself, sir.
Okay.
I mean, who knows?
I'm asking a question.
Yeah, that's right.
I think it is important.
I'm saying it's important. Yes, it's important. So in other words...
So it's important for all ages.
Most men who are healthy.
Most men are healthy, yeah.
So in other words, we want a nerve-sparing operation, and skillful urologists can do a procedure which spares the nerves and yet removes the cancer. But because of this, a lot of people look to other methods for treating prostate cancer.
And they are?
Well, you know, when it comes to treating cancer, they usually fall into several groups. The one important group is a kind of radiotherapy, and a radiation therapy. But it's not all radiation therapy is not all the same, because sometimes you can put little seeds of radioactive substances insert them into the prostate, and they have this kind of halo of radioactivity which kills off the prostate. So that's one method that may be used. The other is the external beam, which may be used to actually irradiate the prostate. And if there is evidence of spread, the beam...
Is that the same as proton?
No.
That's different.
This is regular radiotherapy.
Okay.
Proton therapy, I'm so glad you mentioned, because proton therapy is an advance that has been brought to the world largely by Loma Linda University.
Located in Southern California,
Located
right?
Loma Linda, Southern California. And proton therapy is a most fantastic therapy because the proton waves can actually be contoured, which you can't do. Radiation goes in a straight line. The protons, they can actually contour it a little bit so that they can actually deliver these protons into a given shape.
Alan, I'm very interested in this proton therapy at Loma Linda University. You know, people today, being in the area of nutrition, people are concerned about microwave ovens. Now, how does this proton affect the rest of my body? Does it, well, you know, it's designed for the prostate, but what about other parts of our body? Does it affect that at all?
Well, a proton is a subatomic particle that is put in to this very, very prescribed place. And it's not going to affect the rest of your body. It's only going to affect that particular portion where it's focused. Then it's going to diffuse out and disappear and dissipate. Of course, it's not just prostate therapy. This can be used for many, many different applications. So it's a wonderful, wonderful advance. In fact, MD Anderson is just in the process of getting one installed.
Where's that located?
That I don't know whether I can't give you the location. And
it's in Texas, isn't it?
It's in Texas, I think, but I'm not
Houston,
sure.
I think.
And so is at Harvard. They have one in Boston. They have one of those. These things cost millions of dollars. The one at Loma Linda, I happen to know, was developed there. Dr. Slater was the doctor that put that, and his team put that together, and it cost many millions of dollars to get into place. But a very, very effective and proven therapy for prostate cancer.
Now, I'm very interested. You've first talked about options that a person may have that's been diagnosed with prostate cancer. First of all was surgery, then it was radiotherapy, then it was the proton. Now, is this the order that usually you're treated in?
Yes.
Is surgery the first before For the proton?
This depends on the stage. Remember?
Okay.
So when we get to more advanced forms, then prostate cancer is very often dependent on testosterone, male hormone, to fuel its fire of cell division and so forth. So by blocking testosterone production, either with certain medications that block it, so there are testosterone blockers, there's also a substance called a GnRH analog, which is actually a pituitary stimulator, and it can shut the pituitary production of luteinizing hormone down so that we don't get the production of testosterone. That can be used, things like Lupride and some of those medications given by injection or pellets. And then, of course, there is another surgical approach, which is in a way and indirectly a kind of medical therapy, and that is castration to remove the testicles so that they do not produce testosterone. So, yes, we have a full range of treatments.
Now, there's one you haven't mentioned, though. What about drug therapy? Any promise there?
Yes, drug therapy, chemotherapy, there are many agents that will attack rapidly dividing cells. But in practice for prostate cancer, we tend to find that the therapies have been more along the lines of these hormonal manipulations. Occasionally, a person will get severe bone pain, and that will respond oftentimes very well to non-steroidal anti-inflammatories. Later on, it may be more powerful medications will be required. And on occasion, a shot of radiation to a lesion in a bone will relieve bone pain. So many therapies, a team approach to one's care. And that's why, yes, the second opinion is very important.
I'd like to leave the last minute or two to prevention. Now, there's a lot of herbs. You've mentioned, I think, sauce pimento. But what about prevention or, what about prevention? Is there any way we can, keep from going through getting this surgery or this proton therapy or radical prostatectomies and so on?
The literature has looked at that, and the Adventist Health Study done out of Loma Linda University has looked at that in great detail. Baldwin presented a paper that suggested that the regular consumption of tomatoes provides sufficient lycopenes, especially if they're cooked tomatoes, give sufficient lycopenes to reduce the risk.
Okay, what else? Quickly.
Well, I think that's the main one. Soy products are another. Soy milk, a daily glass of soy milk may be very helpful.
I think the Loma Linda study showed that those who had 2 or 3 glasses of soy milk had a lot less prostate cancer. That's a possibility.
But the study was not sufficiently broad that we can make a definitive statement that if you drink soy milk, you won't get prostate. Remember, with all of these things, although lifestyle can lower your risk, it doesn't always prevent it.
Alan, that's a very good point, and I'd like to thank you today for being our guest. It's been a pleasure of discussing this topic with you.
It's been a pleasure for me, too, and a privilege. Thank you.
With our audience, I'd like to leave one other point, and that is if you are diagnosed with prostate cancer, it's not your fault. And God can be with us during this time of need.